Good morning. For the next session on gallbladder, we have Professor D Yadav from PGH Chandigarh. He'll be showing us a stepwise approach to safe hepatocogenostomy for BBS. Dr. Yadav, of course, doesn't need any introduction.
Thank you, sir. Thank you, and Suprabhatam, all my seniors and friends. What I have done today in my video is that I started with the steps-wise how to go about a safe hepatocogenostomy. So you have to remember a few things before you start. The first surgery is the best surgery, and the number of the reoperation increase the complication. There is very important step. Appropriate patient selection is also very important. And you have to have a good roadmap, correct coagulopathy. Patient should be free from the sepsis. If you don't have a good roadmap, you cannot clear out the ducts. So these are the very important steps to have a safe cholecystectomy. There are special situations other than normal, and we have to have a special methods to tackle this special situation. Like this, by biliovascular injury, one should never be doing early repair. Preoperative tube placement in a separated duct, type 4 and type 5 structure will do it.
Dr. Yadav, sorry for interruption. Your video is moving faster than
yes, sir.
You can pause in between if you do.
Yes, sir. Just a little bit, just because of the time, I thought. So hypertrophy-atrophy complex is very important. You should know it. And if there is an MRCP duct is connecting to each other, it means you did not to have a hepatectomy. But if not, then you have to have a hepatectomy of the atrophied side. Then duodenal fistula. We will not have a duodenal fistula, internal fistula, dilated duct. Here you have to be very, very careful. Then secondary biliary cirrhosis. So these are the very important things we have to understand in the preoperative period. And if you don't take care of all these things, your outcome is not going to be better. And on the table you will have lots of problems. So that's to see the MRCP of the secondary biliary cirrhosis. And some of these patients can be managed by hepatocogenostomy. Most of them will not require liver transplant. So what is our aim? Aim is safe hepatocytosis without injuring any viscera. And then important steps are, we have to go from right to the left so that we are not injuring. So this is very important. This thing is sketched by one of my registrar. So if you are going directly, if you are going directly, it is not stopping, I think some. So if you are going directly, I will take some time here. We start from this virgin area and go lower down the hepatic flexor and reach here from right to the left. If you want to go directly, duodenum would be somewhere here, and you are going to injure the duodenum. Any extra injury is going to affect the outcome. So it's very, very important that you go slowly, hug the base of the liver from segment 6, proceed toward the segment 4 base, and this is our area of interest. So it's a duodenum sketch. So if you are working here, again you are going to have the injury. So we should not have any injury, we should not have any complications other than what we have in our hand. So that is very, very important in a biliary stricture surgery. Then after reaching there, hug the base of the segment 4. So when you reach there, what are other important steps? So this is another very important step, that this is the hiral plate. We have our dissection of the cadaveric dissection. Here this is the segment 4 base. This is the landmark of the left hepatic artery. So you should not go beyond that. This is for the dissection required sometimes to catch the right hepatic duct. So if you go to do this dissection Mercado technique, then only you can have the right hepatic duct, which is usually covered in this area, covered from the liver. So this particular dissection is required. And you can see that at the base of the segment 4, there is no other structure. So if you hug this liver, you are here, this is the left hepatic duct, this is the right, and you dissect like this. So this is all, it is going to be shown in the video. So this is very, very important when you are doing hepatocogenostomy. Then identification of the duct, as I said, and then doing a good anastomosis, which should be away from the fibrosis, which should be away from the ischemic area, and which should be very vascular. So I said that putting this incision like this and clearing the right hepatic duct is very, very important in a difficult scenario. Even in type 1 and 2, this is not a good area to anastomose. So this is the good area as it has been shown. And this is also an area which is compromised vascularity. So one should not be doing this. Then post-operative care, we do liver biopsy as a routine, drains are placed as required, and incision is made. Usually you have an incision already when you have a biliary stricture patient. So going now step by step, showing this thing. So as I said, there are two components of adhesive lysis. One is general adhesive lysis, one adhesive lysis to find the duct. So one lever mobilization is very, very important. So we put sometimes a sponge. So this is what I was going to suggest in my sketch. So you have to come like this. So your left hand should support the lever very gently, and you go using monopolar cautery, bipolar cautery, scissor, not the blunt dissection, because you don't want to injure any Glyconian capsule. Unnecessary bleeding is going to affect your outcome and even your mindset. So unnecessary bleeding should not occur, and very slowly proper cautery setting is also very required. And if you work like this, go to the base of the segment 4 base. This is the segment 4 base. As I said here, you come here, lowering the duodenum, and your friend who should be your senior most registrar giving a counter traction in a cautery so that you don't injure anything. Using, as I said, duodenum is here, and you could see by the, you will see this is the duodenum. So if you are coming properly, you can take the duodenum down without injuring it, and appropriate use of cautery, meaning thereby setting up the cautery, duration of the use of the cautery. These are very, very important steps when you are doing going searching for the duct. So this is a video of the segment 3 duct, type 3 benign biliary stricture. So here you are seeing some bile has been seen. So sometimes you are very happy to see this bile, that you are going to have the duct somewhere there. It's very, very important to search for the duct. So here we are using sharp dissection by scissor, because we know that there can be many vascular structures, important structures, so we should not be injured. So this fibrous adhesion, non-vascular adhesion can be dissected by the scissor only. One can have, if one has a cautery and a scissor, it is also good technique. So as I said, I am holding the segment 4 base. So segment 4 base is the key. Base of the segment 4, if you see the anatomy, there is no other structure here. Only structure most superiorly would be hepatic duct, nothing else. So if you dissect here, try this clip you are seeing here, we are not touching the clip. Our target is this area. So this area is our target. So, and this dissection is also important to see the segment 4, right hepatic duct. This area dissection, this particular dissection is also very important. Here you are using bipolar cautery. We know that setting up a bipolar cautery and tissue injury is much less common. So we come here, you start bipolar cautery using bipolar cautery. Then clearing this area by the bipolar cautery. So this is very, very important. Appropriate use of energy sources, sharp and blunt dissection as required, and scissor use as required. Not trying to go here. This is very dangerous area. You can injure more, especially right hepatic artery injury if it has not occurred, might occur. So this is very, very important to clear. Each and everything must be clear before preparing yourself for this thing. This is very important step. Then going here and identification of the duct by aspiration, smallest possible needle, and taking a stage suture before opening, because we should always have a stage suture before opening. We take a 5 OPDS for the anastomosis, same suture is taken for the stage suture for the opening the duct also. And then you could see the bile, you become very happy that we are at least ready to open the duct without any problem. And then opening the duct, see you see nicely open duct. Then you create a rule loop. Rest is all proper anastomosis. So as I said in the beginning, that it should be away from the any type of fibrosis. And this is the left hepatic artery. Left hepatic artery has been looped. Here in another case, here you could see that the duct is left hepatic artery is coming little bit more toward the right side, and that's why it is crossing the duct. So we have looped it and gone beyond it. So somebody talks about size. We say as big possible as I can do in this type of setting. So left hepatic artery has been used, and then taking interrupted sutures, posterior layer, you will see this, clearing the duct. You could see a good nicely open duct, right and left duct all has been opened, and lots of fibrous tissue. So sutures should not be taken in this fibrous area. So we usually prefer a loop of about 45 to 50 centimeter, and angle sutures are taken first, 5 OPDS. We use magnification to make the things very clear, and then after that taking the bites hardly 2 millimeter depth and 2 millimeter away from each other. That is what is our aim, to take the bite posteriorly first. We don't take classical Bloom-Gutt technique, that anterior, just to save the suture. Same suture you use in the anterior. And another advantage of this type of anastomosis is that you are not going to have you're not inside. So this is also important. And then coming from left to the right and finishing posterior layer on the right side, then same technique. There is nothing very new about being about it. So most important is identification of the duct without any injury, and then trying to avoid taking sutures. Here somehow we have taken little bit of sutures in the area which is not very good, but ensure that you are taking mucosa, and then take the small bowel close to this thing and start tying, and same technique is followed in the anterior layer also. So there is nothing big, tying properly. And we always tell our resident that your pulp of your index finger should be on the jejunum, not on the bile duct side. So there should not be any chances of the cut through. In posterior layer, any cut through is going to hamper our outcome. So we don't want that. So we take a proper suture. We take suture very close to each other. Sometimes somebody may say that lots of suture have been taken. Usually 12 to 15 PDS 5 was required to have a very good anastomosis. So you could see that we have come to anterior layer. Same technique is followed. Same technique again. Good way of taking. Always ensure that you are able to take the mucosa. This is very, very important. Little bit difficult for us when you are not having, but 1 or 2 sutures sometimes we take to lift the anterior layer also. And same as we take in the posterior layer, same technique we use for the anterior layer. And this is almost done hepaticogenosmy. This is what is the sutures have been taken from again left to the right, and sometimes we have to change some sutures to take the proper bite, and then we put a drain as required. Sometimes we don't nowadays, but earlier we used to put drain in each and every case. So just tying, no need to go into more details, but we are doing a liver biopsy in each and every case and try to measure the size of the stoma. So this is all about. I will try to emphasize once more. Liver biopsy is being taken. Core biopsy we take. We don't take surface biopsy. So try to just emphasize once again that safe hydrolysis, identification of the duct, and proper anastomosis. Thank you, sir. Thank you for your kind attention.
What's the long-term follow-up?
Sir, we have now follow-up more than 15 years now. And same thing we are using.
Sorry, you didn't put a stent in.
No, we don't put, sir. We don't put a stent. Only in the cases where we have already put a pre-operative stent in a right hepatic duct, usually. Sometimes, rarely in the left. Then we keep that stent in the duodenum, transanastomosis. Otherwise, you don't put a stent in this anastomosis.
I always do it. And what's a long-term follow-up?
Sir, I have 2 bile leaks in more than 350 cases. 2 bile leaks. One was I was forced to do in a biliary ascites because of some problems with the patient. And another bile leak was in type 4 injury. Right angle was not very clear, but that patient is also doing very well.
Last question from me. And have you done it for portal biliopathy?
Portal biliopathy, hepatico, no, sir. This done in another case. We have done portal biliopathy, not without shunt. I have done after doing a shunt procedure.
A good video. Yeah, please.
Dr. Pareshwarati, Mumbai. I really enjoyed your video. It demonstrated the technique very well. Just a point I like to add, that if you don't have a real wide anastomosis which you want to do, I tend to use the diamond technique. That means you allow the biliary opening to widen a little bit to allow patency to happen longer. That's all. What's your comment on that?
So whatever technique you use to have about 3 centimeter anastomosis is good. So my take is that if there is a bridge between the segment of 4B and 3, I just cut the bridge. That gives another 1 millimeter to 2 millimeter extra space. I go as much to the left as possible. Toward the right side only we have some problem, then we core the liver. So aim is to have a good wide anastomosis. If you have some technique, I have never done it. If you have some technique which can do the same.
What I meant is one achieves a wide anastomosis as much possible in the restrictions of difficult problems.
Yeah.
Perhaps a diamond-shaped opening of the bile duct may allow patency for a longer duration. That's what I said.
Okay, thank you, sir. So, you saw the separation of the fibrofatty tissue and lowering down the plate. Without doing that technique, we cannot reach there. So that was done. That was done. I think you missed that part. If you lift the segment 4 base, and then after that, I used the scissor to divide that particular fibrofatty tissue. I said in my talk that I don't do it for the simple reason that I'm very comfortable to do with the 5 PDS, and we lift sometimes. In a difficult area, there is no ego problem. In a difficult area, we lift sometimes 1 or 2 sutures. I use the same suture and then anterior layer. We work in a government setup. We have to see resource also. So I use this just to save the suture. So 15 sutures I take. That 50 suture will cover both anastomosis. If I do the same Bloom guard technique, it is going to take 30 sutures. So it is almost half suture is required.
Hello, sir. Sindhu from Kotte Medical College. Sir, when the patient with a bile duct injury is referred with a documented arterial injury, what are the options that we have?
First, very important option is no early repair. Even if you are very fond of early repair, please don't do it. At least 3 months. Redo the MRCP, and then accordingly you decide about that. So artery acute injury, if it comes, we are not doing at all early repair. So if right hepatic artery comes, we will definitely not do it. That is the most important message. If you do after 3 months, usually there is no difference in the technique. Same technique can be used. You have to see the type of stricture and take care of all the strictured area.
Is it safe to do biliary anastomosis when there is a documented arterial injury?
I'm saying at early documental injury, all the complications of the right hepatic angina would occur within 1.5 months. So most of these, and 100% outcome of the right hepatic artery injury will be finished by 3 months. So early repair is absolutely not required, and that's why I said early repair is not done. You do after 3 months, do MRCP recent, see what are the type of stricture, where are all the strictures. You might require to do sometimes right hepatic. As I said, I'm not very fond of doing liver resection. I usually don't require. The one patient I showed, if there is a communication between the duct, both the sides, then we don't do resection at all. If there is no communication, it is separated and atrophied, then we go and do it. So if you remember my cadaveric sketch, cadaveric photograph, so we have put a incision. So you can reset the segment 4B little bit toward this right side and segment 5 in the gallbladder bed. So like Mercado technique, you put a good incision semicircular and go as high as possible until unless you get a good duct. Sometimes you will have a separated anterior and posterior. So up to that level you can go very easily. I will be very hesitant to do in a benign disease whatever is possible. We have to ensure on the table. You can call your senior, you can do intraoperative ultrasound. Whatever you do, all the structured area has to be drained. That is the basic principle.
Dr. Sadaf.
I am Dr. Sadaf. Anybody else? Yeah, I am Dr. Sadaf from Sher-e-Kashmir Institute, Srinagar. It was an excellent video presentation of a very difficult area, bile duct injury, where we have to record it. It is a challenge. I would like to know from your experience that what would you do if you have waited for around 2 months or plus and the leak is on. Some people don't heal well.
So you
and I do go in and repair them after a particular time period of
3 months is our take. I know Professor Blumgart, sorry, lately he's this thing. He and Professor Bismuth always say, wait. We go 3 months, little bit more than 3 months. After 3 months, usually fistula don't heal. So as I said, it will be little bit undilated duct, but it can be taken care of appropriate technique what we use.
And would like to know about your follow-up of hepatico-jejunostomy site stricture, because that's the main tough thing, as wide as you do, as bigger as you do, but you have to do some interventions later on.
2 patients of our patients who had already secondary biliary cirrhosis at the time of the presentation, they are on follow-up and repeated dilatation. The most important thing is presence of fibrosis at the time of the surgery. So if patient is have fibrosis, it progresses on and on, even after your decompression. It might go slow. So otherwise, most of the patients, all our patients are doing very well if we follow the same technique.
So it's a very low incidence when compared to...
Yeah, one last question from me. See, many of these cases have duodenum pulled up, almost up to the hilum.
Yes, sir.
Have you ever considered doing a hepatico-duodenostomy?
Sir, not in biliary stricture. I have done in CA gallbladder.
Any objection to it?
I did not do in biliary stricture. Sheer fear of taking a new technique in a patient of benign disease. But we are doing regularly when we are doing excising common bile duct for CA gallbladder. So I routinely do hepatico-duodenostomy.
I have done 3 of them without much of a problem. You avoid creating another root loop, and duodenum is so close, of course, you are quite
it can be done,
selective about it.
It can be very nicely done. The only thing is that, as I said, I am little bit scared to go about that.
Thank you, Dr.
Thank you, sir.
Yadav,
Thank you.
for a wonderful presentation.